Good evening and welcome to UPMC Sports Surgery Clinic Public Talk. I'm Fiona Roach. I'm the Business Development Manager here at the Sports Surgery Clinic. So just a little bit about the hospital before we start. For anyone that doesn't know us, we are the leading private orthopaedic hospital in the country. We're about 10 minutes from Dublin Airport and just off the M50 and the M1. And we specialise in all orthopaedic surgery, including hip and knee replacements, shoulder replacements, and then shoulder surgery, ankle surgery, foot and ankle, hand, and soft tissue such as ACLs, and we do arthroscopies as well of all joints. We've got 7 theatres here and 3 MRI scanners, state-of-the-art sports medicine department and physiotherapy department. So tonight's talk, we've got 2 speakers with us. We've got Professor Cathal Moran and Dr. Ronan Kearney. Now, both of them are going to join us live after their presentations for a question and answer session. So please, you see the tab there, ask a question, type in your questions there, and we will endeavour to answer them all. So we're going to start off tonight first with Professor Cathal Moran's talk on ACL injury and knee injury. Thank you.
So good evening, everybody. I'm Cathal Moran here at UPMC Sports Surgery Clinic. And this evening, I'm going to speak to you a little bit about ACL injuries or anterior cruciate ligament injuries. Just to give you a little background, I'm an orthopaedic surgeon by way of background. Also the chair of orthopedics and sports medicine at Trinity College Dublin. And my practice team and I focus our interests on the management of injuries, and particularly sports and soft tissue injuries of the knee and shoulder. But I suppose this evening's interest or discussion is around anterior cruciate ligament injuries. And maybe rather than actually going through a bunch of slides this evening, I'm going to speak a little bit off the cuff in relation to this. Maybe show you a little video of how ACL surgery is actually done, and then maybe take any questions you may have at the end. So I suppose the anterior cruciate ligament, or ACL, is one of the key ligaments of the knee. It's a central stabilizing ligament. This is a knee model here. We're here in the office this evening. This bottom bone is the shin bone. This area at the front is the kneecap or patella. But when we look inside the knee, you'll see a couple of key ligaments. And the anterior cruciate ligament is this key ligament in the middle of the knee, which we find to be very important for athletes and players, particularly those involved in what we call cutting sports, which we have a lot of in Ireland, or GAA sports or field sports. When one goes to cut or turn, or when one goes to decelerate from a high-speed run, that ligament kicks into action and provides a lot of stability to the knee. And I suppose we know from injuries that very few athletes nowadays seem to be able to cope or manage to play when that injury occurs. We see it in all sports. We see it in our rugby, we see it in hockey, we see it in GAA. But what we do know is that it's primarily what we regard as a non-contact injury. One doesn't actually have to pick up a tackle or get hit for it to happen. It can simply happen by planting the leg, going to cut and turn, and classically the athlete or patient will describe everything, or describe the knee popping and giving way beneath them. I suppose, how does it happen? Well, as I said, it happens in those field sports: cut and turn, knee buckles, gives way, collapses. Often the player or the players around them will hear of a pop. They'll suddenly see the player collapse to the ground. There are times the player might try and get up and get going again, but unfortunately, it often doesn't allow it, and even in the same game. So then, often in terms of early assessment, well, as I say, the athlete will often try and get up and get going on the field to play again, but classically it will give out, and that's a key first sign. Swelling is very classical or very typical in the early stages following these injuries, certainly in the first 24 hours, and often even in a shorter period than that. And there are only a few things that can cause the severity of bleeding and swelling that the ACL injury is associated with. What about early assessment then? Well, nowadays, thankfully, most athletes and teams have access to physiotherapists, be it on the field or follow-up clinics and so on, where they can get assessed in rapid access. And classically, the story, or history as we call it, gives the game away as to what has actually happened. But then from there, one typically would come on to a specialist sports surgery service like our own for further assessment. And we use a number of evaluations. We do go back over the story. We do take the history again. I classically examine the knee. And by that, I mean we can see in the knee when it's evaluated that there's a certain amount of instability. We can see, for example, that the tibia in a torn ACL knee will slide forward a little more when we evaluate it. And that's what we call the Lachman test or anterior drawer test. And these are specific tests we use. The next thing then we actually go on to do, and typically we can do nowadays, is use an MRI scan. And the MRI scan usually is like the icing on the cake, and it gives us all of the final information as to what might happen. In addition to confirming that the ACL is probably torn, we can also see other clues like what we call a pivot shift pattern of bone bruising, where we see bruising within the thigh bone and the shin bone, which often documents the mechanisms of injury by which it would have happened. Other ways an ACL can happen are through hyperextension, or there are some more unusual ways, but the most common is what we call the pivot shift or twisting or cutting injury and that hyperextension type mechanism. So that then brings us up to the athlete with the torn ACL and where we go from there. Well, as I said, we do know that maybe up in 20% of GEA injuries are ACL injuries at this stage. So obviously in a country where there's so much interest in field sports, there is a lot of interest in getting these athletes back to play. There's often some debate about whether some athletes can actually cope with an ACL tear and may not need surgery. And they're the type of things that we discuss here in the practice with you when you come along to discuss the ACL or when athletes do. There are certain patients we regard as copers, certainly those people who might be involved in sports like cycling, maybe swimming, straight line activities. They may get away without ACL reconstruction. But for the vast majority, we would feel nowadays in that classic high-risk group between kind of the ages of maybe 15 or 16 and 25, 30, playing a lot of field sports, that the ACL does need to be reconstructed. I suppose a lot of work needs to go into the background before we actually get to what we call an ACL reconstruction phase. And classically, the first thing we do following any knee injury, and I suppose it's important to realize it's not just an ACL injury, it's an injury to the whole knee. By that, I mean, we get soft tissue swelling of the entire knee. We get a lot of apprehension, a lot of fear of movement. And in the early stages, we tend to go down the line of what we call prehabilitation or recovery of the knee, essentially, after injury. And this classically is something that we would do with the help of your treating physiotherapist close to home. We can work with it. We have our own internal team of clinical specialists here in the practice, both from a sports medicine and nursing background, a physiotherapy and rehab practice. But we also look to work with physiotherapists and specialists from all around the country. And we find that that byway communication often gives the best results we can. So in the early phases, the first thing is just to, I suppose, diagnose the injury, reassure maybe the athlete, reassure the parents and so on if they're involved as to the nature of the injury and what we might do about it. So then what about the preparing for surgery phase? Well, it's really about getting what we call normal homeostasis, or getting the knee back to normal. But that, I mean, getting the swelling down, returning the knee towards normal movement, really ensuring full range of movement if we can, and so on. The other thing we like to do in the early stages with the MRI scan is confirm the presence of otherwise of what we call the other comorbid injuries, whether there's any damage to the cartilage, the lining of the knee joint, whether there's any lining or damage to the meniscal soft tissues, the little wedges that act as shock absorbers within the knee and so on, because they're important for what we call prognostic indicators. They can influence how well the knee will do over time. They can also influence whether we need to intervene rather urgently or whether it's something we should wait for a few weeks before intervening. Sometimes where there's a large tear of a meniscus or what we call a bucket handle tear of a meniscus and so on, we might need to go a little earlier to surgery to get that settled down. But normally we like to give anything from 4 to 6 weeks in the early stages to get the knee settled, get the swelling settled and get it ready for surgery. And I suppose the next step, just to explain to you how surgery typically happens then, well, when a surgical procedure is required, ACL or anterior cruciate ligament reconstruction surgery in my hands is typically done using a one-night overnight stay in the hospital. And as the athlete or patient, they would classically come in on the day of surgery and stay the night of it. So what I might do now is actually take you through a little video of how I go through an ACL surgery. This is more of an animation, just so you can understand it. I'll speak a little about graft choice and things as I do so and take it from there. So here we are looking at essentially an animation of a knee. And here is the anterior cruciate ligament in the middle of the knee, which is the key ligament which gets torn and we need to reconstruct. Here to the side, you'll see 3 what we would call graft options. In the middle is my preferred graft of choice, known as the patella tendon graft. And it's my preferred choice because at either end we have some bony attachments, and these will integrate well into the tunnels which I will create. Another option is that known as a hamstring graft, which we use on occasion, and also a quads tendon graft. Essentially, it's these grafts that are used to reconstruct the ACL as need be. So when we're undertaking a procedure, one of the first things we do is actually obtain the graft. And as I mentioned, the patella tendon is my preferred graft of choice. And where you see it coming from is here at the front of the knee. This is the patella or the kneecap, and this is the tibia. And essentially we harvest or remove an area of about 70 to 80 millimeters in length. And this essentially will be used for the ACL graft at the end of the day. So one of the first things I do when I'm actually doing the ACL reconstruction is we'll go into the knee with the camera and a little shaver to remove the old torn ACL. Now you can see it gone here. The next step then is essentially to drill little tunnels in the shin bone and in the thigh bone, and it's through this area that the new ACL graft will be placed. We do this again all in a keyhole manner, keyhole technique. Here you'll see it being pulled in with what we call our guide wire, being pulled up into place. And this is how the ACL or anterior cruciate ligament reconstruction is undertaken. The last aspect of the actual procedure that's key is the fixing in place of the ACL with screws. So that's really it. That's our new ACL in place. And once this is done, we essentially bring the patient back to the ward, allow them some rest, and commence rehabilitation. So obviously that is the key aspect of what we call anterior cruciate or ACL reconstruction with the use of a patella tendon graft. But that really isn't the whole story, obviously. We've had the diagnosis, then we've had the prehabilitation, and the next we move into what we call our post-operative or rehabilitation phase. The first thing I suppose an athlete needs to know is that typically we'll be using crutches for 2 or 3 weeks following the procedure to allow the initial healing start. And I suppose the emphasis in this first post-operative phase is we're working with both our own clinical team and indeed the clinical team around the country to get the knee moving back to its full range of movement, get the swelling down, and get the athlete or patient moving and be comfortable again. Then once we get early movement going on over the first 6 to 8 weeks and get things moved along, we move into what's known as the strength phase. And this involves building up the strength in the quads, in the various pelvic musculature, in the core and so on, to essentially move this over the following 3 or 4 months towards the knee and limb that's strong enough to eventually start a return to play program. Now, there really is a multidisciplinary approach to this. Obviously, a lot of it's based around physiotherapy early on. Then we strengthen conditioning and we follow very specialist guidelines in this regard. But there are other key aspects that are very important. And these are often neglected, or we see maybe many athletes need support with this. This typically involves proper nutrition, proper hydration, proper sleep, and I suppose being able to maintain the motivation and the psychological supports that go with being able to keep your training going, often in isolation, often over winter periods when the teams are usually playing with or playing away. So these are key aspects to why we would have regular follow-ups with the athletes and patients over the few months to follow, giving feedback to their physiotherapists, to their families and so on. But these are all key aspects of doing well in the long run. It's not solely a time-dependent manner, but we do think it takes in the region of maybe 8, 9, 10 months, and sometimes even longer to rehabilitate not just the knee, but that athlete back to a level where they may be able to eventually return to sport. We do that, and eventually we do some what we call biomechanical testing or isokinetic testing, where we get some objective measures here at our sports medicine center at UPMC Sports Surgery Clinic, and that allows us to guide the athlete further. So it's part of it's clinical, part of it's what we feel and see the athlete doing, but there are also some objective measures that we use. And eventually, at the end of the period, together we make a decision in relating to returning the athlete to play. I suppose the one thing to think is when the return to play period comes, that again has to be handled very carefully. We know that fatigue can set in very early and very quickly in our athletes towards the end of their programs. And essentially, it is important that they gradually build up their time, that they're able to do their cutting, that they're able to do the basic activities in a non-contact manner before they go into full contact. And even when they go back to full contact, they maybe build up their play maybe 20 minutes at a time and don't just launch into full-scale games, because that probably would increase the risk of re-injury. So that's really some classical stuff around ACL care and how we take them through it. I suppose there are a few other key points that we would like to make. I mean, there are some particularly high-risk groups that you'll see us taking particular care with. We know, for example, the rate of ACL injuries in females is much higher than males. We think part of that's anatomical, to the way the body's set up, the way the knees are set up, but we also think there might be some flexibility or hormonal issues that play a role. So we take particular care around our female athletes to ensure that they're given the proper support. The other group there that we would like to kind of discuss are our youngest athletes, because we know that if you have an ACL injury under 16 years of age, your chance of having another substantial knee injury or ACL injury in that same or other knee might be as high as 20 or 25%. So it's very important that they get treated, get assessed properly, and they get guided back towards a proper rehabilitation program, and that we take our time in getting them back to play. What then about, I suppose, that brings us back onto the bigger question about ACL prevention and so on. And thankfully nowadays, there is an increasing interest around this. The GEA have programs out there, FIFA have programs, World Rugby have programs. But probably what's most important, even at a local level, is that our young athletes and athletes of all ages, in addition to playing, are putting time into basic strength and conditioning, basic flexibility and so on. There's a tendency nowadays to be playing, but perhaps without enough emphasis on background training, background warm-ups and so on. And one of the key messages I'd like to come out of the chat this evening is that this is key to both preventing our athletes from injury at ACL and indeed injuring many other structures around their joints or having to take time out of the game that they love. What about research then? Well, we have a lot of clinical research going on here at Sports Surgery Clinic into not just why these injuries are happening, but optimizing our rehabilitation programs, how we can get athletes back, not just quicker, but keep them back. It's not just about getting back to the game, it's also staying in the game. That's probably the most important thing of all. And we're constantly doing research as to how we can get our rehabilitation programs better, what other factors we can address, all the things that give the small increments to keep our athletes back safely and keep them back safely in the game. Other research we do, I work with a group at Trinity College Dublin who are doing some what we call bioengineering or regenerative medicine research, where we're actually looking at how we can augment ACL healing. Maybe we don't have to actually replace or reconstruct all ACLs. Some may actually be possible to heal, and looking at particular groups, where that might be possible and how it might be possible with synthetic grafts and so on. The last thing then, I suppose we might address, or what people are concerned about, what are the long-term sequelae? Well, unfortunately, when you have any substantial injury to a knee joint or to any other joint of the body, we do recognize nowadays that there can be long-lasting effects. And typically, probably, I suppose, the one that people worry about most is something known as post-traumatic osteoarthritis or wear and tear over time. We do know that maybe up in 25% of athletes who have an ACL injury might need another surgery on their knee over the 7 to 10 years. This mightn't be a major surgery. Sometimes a little keyhole clean out of scar tissue, of damaged cartilage, of damaged meniscal tissue and on. But often the ACL injury is, I suppose, the start of some issues with the knee. And I suppose that's why being associated and cared for in specialist centres and specialist hospitals is important, so that you get the correct diagnosis early on. So when these little niggles do arise, that we can help you address them and deal with them. So that's really it in a nutshell. We are taking, RT have recorded a program with us recently where we are looking at an athlete who has undergone ACL injury, who's having treatment here at Sports Surgery Clinic, and how we might be able to take them through the program. So for those of you out there tonight who are more interested in this, we'll be on, I think, over the next couple of Tuesday nights, and it might be fun to see as well as a follow-on from the study, or tonight's chat. But of course, I'm available to chat at any stage, or any of our clinical team here in the practice of clinical specialists to help you in any way we can.
Hi, Carl. Thanks so much for talking, and it was a really interesting talk. We're going to start with some questions that are flying in there from John Kelly. What is your current view on the application of stem cell surgery for knee problems?
Yeah, great question. Something we get asked a lot about nowadays. I suppose, in truth, I would have to make the declaration that there are no true stem cells available for use in orthopedics outside of clinical trials. Unfortunately, there are a lot of sort of, I don't know, false or misleading suggestions made by some clinicians that the HAMs have stem cells available for use. They're not really. They're mixtures of cells from the body, but true stem cells aren't available for use. Evidence would suggest that there's some role for them in reducing inflammation, but there's been no proven benefit as of yet that they can actually create cartilage regeneration or other such facilities. Really, it's another immunomodulator, pain modulator, and so on. It is important that when patients do go down the line of using stem cells or speaking to people about them, that they're properly consented and attend a reputable centre where they're properly informed.
Lovely, thank you. Then as a meniscus tear, should I continue walking? I have started physio, and can you recommend activities to partake in to improve it?
Yeah, I suppose meniscal tears, I suppose the menisci are some of the key structures internally in the knee. We regard them as playing a role in shock absorption and weight distribution and so on. I think as such, they're naturally going to wear out over life. So by the time we go into our late 40s, 50s, 60s, and so on, if we have an MRI of our knee, it typically will show some form of meniscal tear and so on. The vast majority can be treated without surgery. They can be treated literally with exercise, movement, and so on. The symptoms may wax and wane a little. There are times we have to go in and clean out the knee or remove the damaged tissue if it's causing mechanical problems or it's not responding to exercise. But the key thing I would say to most patients is to keep moving and to keep exercising. The last thing then, I suppose, is there are some other forms of meniscal tears that can occur as acute traumatic large meniscal tears in our younger athletes, and they're often something that we should give an early opinion on and decide with the patient or athlete whether or not we would intervene. Some can be repaired, some not, but that's when an opinion should be sought.
Oh, just carrying on with the meniscus tear, somebody else has said they had physio, they had the cortisone injection, they got relief for about 2 weeks, and would you recommend the plasma injection?
Again, it's a little bit like the stem cell question. There's no real evidence for plasma over the, I suppose, cortisone, hyaluronic acid, and so on. I suppose the other thing, what they really need are a proper assessment with proper qualified sports med physician or orthopaedic surgeon. Sometimes the pain can be arising elsewhere. It can be arising from cartilage damage, underlying bone damage, and so on. It's often tempting to think in the MRI report that the meniscal tear is creating an issue, but really, again, it goes back to really a proper clinical assessment. Yeah,
okay. So as well, are knee supports benefit for knee pain when walking downhill?
I think, I suppose, first of all, it goes back to the proper clinical assessment as to what's going on. I mean, the support is fine, but really most people with knee pain or aches and pains and so on should be in a proper physiotherapy or strength and conditioning program. They can often help. And wearing a support, if you're not doing the background work, probably isn't necessarily the way to go. They don't do any harm on themselves. But again, in a properly cared for environment, proper assessment and so on, I think they can play a role. Okay.
So a question here about another meniscus, and you've kind of answered this about whether they should all be operated on, because some is what concerned about the increased risk of arthritis after having surgery. And can they, I suppose people are saying if they do have surgery, like a knee arthroscopy, meniscus repair, can they increase their risk of arthritis?
It can, but I think what's tempting to think about is always the meniscal tear or the surgery and so on. I think what most people might be best focusing on is maybe a more wholesome approach to their overall health, looking at their weight, looking at their movement, looking at their activity level, keeping themselves strong. Many of those factors probably play as big, if not bigger, role than simply a discrete meniscal tear, meniscal tissue loss, and so on. So while it's true to say there is probably an increased association between meniscal loss and arthritic change, I think it will be important to keep in mind that specialist surgeons, specialist sports surgeons really would be very aware of not removing excess tissue, really just removing the damaged tissue and hopefully facilitating increased movement and function. That should keep the patient healthier overall.
Yeah. And is it okay to run after that, after having that surgery? Someone was asking.
I think it is. I think, again, that goes back to proper expectations, proper counselling and so on is something we often take our patients through. I mean, there are many different types of meniscal tears, cartilage damage and so on. And it's not just simply whether or not you have a meniscal tear, it's the pattern of the tear, its location, it's what's the underlying cartilage like. And then it goes back to, you say, running, but sure, I suppose when we think about running, it's the frequency of running, the intensity, whether or not there are break periods involved, and maybe a mix of sports like a little cycling or swimming can often help as well. But certainly the overall message would be that you can remain fit and active even after having these little injuries and damage, and we'd often encourage it with the proper supports to be done.
Yeah, you've got a couple of ACL ones coming in here now. So This is from Dara Bolton, who's a physiotherapist. He says, is there any need to place an acute ACL into a knee brace, such as the John Joy?
I think this is very helpful. I think the overall message needs to get out when people have any sort of an acute knee injury, that we need to get the proper program in place. And this often involves some elevation initially, some icing, but some movement. I suppose a well-qualified physiotherapist, physician or anything really should be able to identify a knee that's very unstable. That means a knee that not just has an ACL tear, but maybe an MCL, medial collateral ligament tear, PCL tear, lateral collateral. Some of those knees might benefit from a little support with a brace for the first few days until they see a specialist about it. I would generally say, though, a bigger fear we have is of people getting stiff. All too often, I think the past patients would have been assessed with maybe ED departments, maybe not getting access to proper physicians, being locked up in braces, being put in splints and so on. And that stiffness and so on often can be the undoing, or at least the delaying of the treatment. Similarly, afterwards, I would have worked in centres, I'd see it documented internationally, people are using braces or so on. So people who work with me would be very aware that I would be, not that I'm anti-bracing, but I'm very much pro kind of getting it fixed properly and getting the knee moving. I think that certainly serves the patient well in the aftermath. And I think, again, beforehand, that's the ideal way to go.
Okay. Carl's asking, is there any evidence of correlation to coordination of athletes and ACL knee injuries, especially with increase of younger athletes suffering with ACLs? More sedentary, less physical, active childhoods, etc. I think he's wondering, is there a relationship between children being very active and ACLs with those? Yeah.
I think we just to move it away from ACLs alone in isolation. I think it's well accepted at the moment that we have a couple of problems brewing. On one hand, we've probably a group of children in certain parts of our country, certain parts of our cities that maybe aren't moving enough, and they're looking at anything from obesity epidemics to diabetes and so on. Then in other areas, we probably have the opposite. The kids are going from game to game, from sport to sport, probably not doing enough strength and conditioning. Now, I'm not talking about young kids having to be in the gym lifting weights, but proper warm-ups, maybe at least a knowledge of the need to do a basic strength and conditioning program once or twice a week. There's GAA under 12, under 14 teams, rugby, training young lads 3 or 4 nights a week, playing them games a weekend relentlessly the year round. And I have to say, I'm not quite sure that's the way to go. I have children myself. They're very active in sport, but I do think it's important to keep the balance between some training as well as just playing. I think that's probably more important to get out.
Yeah, lovely, thank you. Is there anything in particular that females can do to avoid make them less likely to have an ACL? Is that footwear or anything like that?
I think it goes back to the footwear could play a role, but I mean, one of the great things we see nowadays, I think, is that there are many more females participating in sport, and not just participating, but being supported to participate at multiple levels in multiple schools, and so on, be it clubs and schools. Again, though, probably one of the single biggest things we need to do is to continue to introduce the importance of strength and conditioning into those programs, not just playing, because it's not just about playing sports, it's about being in sport. There can be huge dropout rates following injury, and I think doing that in the background is key. And I think it's probably more important for a child or a teenager to maybe have a game, maybe one training session, a couple of gym sessions, and just be playing relentless. And it's not just ACL injuries. We see a lot of overuse injuries, from back problems through to knee problems in general. And again, it just needs to be the balance between proper warm-ups, proper strength and conditioning, and playing.
Good. Someone has asked here, because this does come up a lot, what would you suggest for Baker's cyst and fluid on the knee? No pain, just swelling.
Again, I suppose what I'd say there, a Baker's cyst has been diagnosed clinically or with an MRI. It can be tempting, I suppose, sometimes just to point to a finding such as a Baker's cyst and MRI and assume that's the cause of the pain. But usually a Baker's cyst, first of all, a Baker's cyst is essentially a collection of fluid at the back of the knee. And what happens is a knee is probably producing excess fluid because of excess inflammation, maybe because of wear and tear and so on. The fluid sneaks out through a little crack in the cartilage and the meniscus, the lining, and essentially builds up because it acts as a one-way valve. So it's fine maybe thinking about taking the fluid out the back of the knee with, aspirating. That means sucking it out in a needle or that. But unless you deal with the internal problem, it's just simply like any collection of fluid is going to come back. So it's important to know it's not a growth, it's not a lesion or cancer or anything like that. It's a collection of fluid. And really, if it's bothersome, consider what might be causing it. And if it's not, leave it alone.
Okay. Someone's just saying with a tear, they had a meniscus. My meniscus has a tear after surgery. They're 52 years of age. Will I probably need a partial knee replacement? As my understanding is, the repair of meniscus lasts only for so many years.
The first instance, I suppose, even in the best of conditions, even at a young age with healthy tissue and so on, being able to undertake a repair of a meniscus is, well, it's possible to undertake it, but it's often unlikely that it will heal. So, I mean, it's important that the surgeon and person assessing have the skill set to decide whether or not it's something likely to heal versus not, so that an inappropriate repair isn't undertaken, just predisposing the patient to another surgery. Secondly, as I say, as we go, and we said earlier on, in our 40s and 50s, 60s, so on, our meniscal tissues start to become a little worn out. Certainly not, and very few people who have meniscal tears end up going on to having joint replacement. That's kind of an extreme endpoint for end-stage arthritis. You might have a little irritation in your knees as the years go on, but as we said earlier, keeping your weight in order, keeping yourself fit and active, they can often be factors that keep things at bay. And nowadays, partial knee replacements are possible, total knee replacements, but again, that's for end-stage arthritis at a whole different level of symptoms than a small meniscal tear might be causing.
Okay. With patellar tendonitis, is there a specific exercise or movements that can be done to help with pain?
There are, but again, it would take a proper assessment because we need to go into the background of what might be causing it. Often these patellar tendinopathies, we think they come from overloading or altered mechanics, kind of maybe altered hip mechanics. We often think about the knee, but it goes back to the core of the body, down through the quads, down through the back, the chain at the posterior chain, through the back, the hamstrings and so on, looking at the balance there, looking at movement and so on, maybe figuring out why that patella is overloaded. That's really that's driving the pain. So rather than just simply saying there are a few exercises you can do, again, it's possible to work through it with physiotherapy, but first of all, to diagnose what might be driving it.
Yeah. Cathal, thanks very much for joining us tonight. And you did mention there that there is going to be a program next week on RT Tuesday night at 8:30, looking at the process and the journey of a patient having an ACL from beginning to when he finally goes out back to play. And that is happening at UPMC Sports Surgery Clinic if you want to watch that. Thank you. And with our next speaker tonight is Dr. Ronan Kearney, and Ronan will join us afterwards for a live Q&A. Thank you.
Thanks very much for the introduction. It's a pleasure to present to you all this evening on hamstring injuries in sport. I suppose a little bit about myself. My name is Dr. Ronan Kearney. I'm a consultant sports and exercise medicine physician. I mainly work at UPMC Sports Surgery Clinic in Santry. However, I also work across a number of different sports, predominantly at the High Performance Centre in Sport Ireland, looking after athletes, mostly athletics, preparing for the Paris Olympics. I've also done some work in the past with European Tour Golf, international teams of the FAI, and also club level rugby. I'm from Louth and I've been involved for many years with their men's football senior team, and I'm also chairman of the Gaelic Athletic Medical Association. And I suppose addressing and managing hamstring injuries has formed a large part of my job, both within the clinic and within the sports I'm involved in. So just a quick overview of today's talk. It's important to understand the context and background of these injuries, as well as the anatomy, to be able to properly assess, manage, and prevent hamstring injuries. This was Usain Bolt, the fastest man in history, during his last race as part of the 4x400 meter relay at the World Championships in 2017. A very unfortunate end to such an incredible career of sprinting. Sprinting is the typical mechanism of injury in hamstrings, and I'll discuss how we assess and manage such injuries throughout this presentation. So with a focus on team sport, hamstring injuries amount for almost a quarter of all team sport injuries. They make up a third of all time lost to injuries also. And a study carried out within the GA found that 26 days was the average time lost per hamstring injury. So if we consider a full inter-county GA team, how might this look for the season? Well, on average, for each team, 9 players suffer a hamstring injury per season. And this will obviously take a toll on not only the player health, but also on the team performance. As well as that, re-injury rates are currently reported in the literature to be very high, often quoted to be 33%. However, some more recently described hamstring injuries involving the tendons can have a re-injury rate of over 60%. So this would either indicate assessment and management strategies are either incomplete or an athlete has potentially returned to play too early. In reality, it's probably a mixture of both. So how might the toll of injuries affect a team's performance overall? This was an interesting study that looked at the estimated league performance and financial cost of injuries for Premier League teams. It showed that the more total days out injured corresponded to a drop in league position. And the authors calculated that 271 days out injured would cost a drop in final league position by 1 place. In Premier League terms, this corresponds to about £37 million. Being a Liverpool fan, I'll highlight Man United in 2016-2017. Man United had a high injury toll compared with the other top 6 clubs, and this had an associated correlation with their league points lost. They had the most valuable team in the league, but not even their manager at the time, Jose, the special one, Mourinho, could counteract the impact of the injury toll. Now, obviously, there's other many factors affecting final league position, but it gives us context of the impact of hamstring injuries within elite sport. So this is a busy slide, and it in no means covers all the risk factors for hamstring injuries. There are some risk factors that we just can't control, such as age or previous injury. However, it's essential to understand that those who've had a previous hamstring injury or even a previous lower limb injury are 3 times as likely to suffer a hamstring injury. It's obvious that it would be sensible to try and reduce the risk where possible on factors that are modifiable, such as strength, biomechanics, and training load. We know that a reduced eccentric hamstring strength is a risk factor for hamstring injury, and as is a number of key biomechanical measures such as hamstring length, ankle, and hip range of movement. We also know that a sudden spike in training load, like going from doing very little to doing a lot of high-speed running, increases that risk. We also know that athletes that have gradually increased their running and high-speed exposure over time have a lower risk of hamstring injury. Other factors such as a new manager with the team, as well as poor communication between medical and coaching departments of a team, increases the injury risk. So really think outside the box when trying to reduce the risk of injury. How do injuries happen? So sprinting is the most common cause of injury, as we've just seen from Usain Bolt's video. However, there's a number of other reasons. This was an interesting study done in rugby, at Leinster Rugby, where we can see that both decelerating in the orange and rucking in the lighter blue colour both sit at 19%. I suppose this comes back to management, and from a rehabilitation perspective, it's important to review the mechanism that caused the injury. This might involve a discussion with coaches on rucking technique to see if there's any ways to reduce the risk of such a mechanism causing another injury. Understanding the anatomy of hamstring is the key to be able to understand and assess the injury itself. The hamstring is made up of muscle and tendon. So let's just focus on the muscle first that we've circled here. So muscle is made up of long muscle fibers, both fast and slow twitch. And when they become active, they allow the limb to move. With strength training, these muscle fibers enlarge. If the muscle is injured, a number of healing steps happen, which we see on the right-hand side of the screen here. On the top of the screen, we see that inflammatory cells fill the muscle defect and a blood clot or hematoma forms. The next very important step is that regrowth cells, which are called satellite cells, stimulate the injured muscle tissue to repair with a scar. The final step is the muscle scars gradually return to normal. If rehabilitation isn't correct, there is an incomplete healing and a chronic scar can form. This chronic scar generally isn't as robust as normal muscle and can lead to an increased risk of injury. Next, to focus on tendon. Tendon is very different to muscle, and tendon is made up of stiff collagen fibers that have a very high tensile strength and have elastic property. They respond and adapt to mechanical loading. The junction between the muscle and the tendon is often a weaker link in the connection of movement. Tendon healing takes a lot longer than muscle for numerous reasons, including the lack of a regrowth cell that we've previously spoke of, the satellite cell that the muscles have. It's slower to heal and requires a cell scaffold alongside a number of other gradual mechanical loading in order for it to adapt and regain its tensile strength. For this reason, a number of weeks rest, which is not an uncommon management strategy, often is the worst thing for hamstring tendon injuries. We look on the right-hand side of the screen here, stages of healing. So the first stage of hamstring tendon healing is similar to that of muscle, where a blood clot or hematoma develops, inflammatory cells fill the defect. Platelets increase and release growth factors to kickstart healing. By week 5, a tendon scar is generally formed. This scar can take up to 8 weeks before it's stronger and robust. With appropriate loading, exercise, and rehabilitation, it gradually returns back to normal healed tendon tissue. We'll often see patients at the sports surgery clinic that have re-injured the tendon in this phase before it has fully bridged the defect of the injury. And the tendon that's re-injured becomes a trickier injury to manage. So we'll just go through some of the hamstring anatomy itself. So the video on the left, we see there's 3 main hamstring muscles. The semitendinosus, the biceps femoris, which has 2 different heads. This is the long head of biceps femoris, the most commonly injured hamstring muscle. If we rotate around, we can see there's also a short head of the bicep muscle that inserts further down. And if we rotate back to the inside part of the leg, we see below the 2 other hamstring muscles lies the semimembranosus, which is an uncommonly injured hamstring muscle. The picture on the right illustrates that the tendons of the hamstring muscles are not just insertion points onto bone. Each of the hamstring muscles have long tendons that span most of the length of the thigh. This makes the diagnosis of muscle or tendon injury difficult by just location of the pain. So are we hamstrung by anatomy? We might be if we don't fully appreciate a few key concepts. Mechanically, the hamstrings cross both the knee and hip joints. This means that they have greater contractile velocity, they have greater capacity to change length. However, unfortunately, they have less capacity to withstand tension. We already know that tendons heal differently to muscle, and this healing phase also takes longer. If we don't respect this, we are most definitely hamstrung from the onset. So can we tell a hamstring injury is either a muscle injury, a muscle tendon injury, or a tendon injury itself? It's often difficult to tell by just taking a history and examining someone. Some clues that may suggest a tendon injury can include a popping sensation, a severe loss of function or strength, large bruising in the area. However, some more subtle signs, such as a higher up injury near the pelvis or a lower down injury near the knee, can sometimes mean a tendon injury. More recently, we know that rotational mechanisms seem to be at a higher risk of distal or more closer to the knee tendon injuries, or a recurrent injury that just doesn't feel right. Think that this may be a tendon injury. This was a study from the GA. So often the initial suspected grade of hamstring injury and the projected return to play time is very wrong. The initial projected time loss was for over 4 weeks was only 2%, but the actual time lost time was almost a quarter. So how do we get around this? So MRI is vital really at identifying the exact location of the hamstring injury. It shows us what structure is involved and takes a lot of the guesswork out of injury grade prediction. The MRI above shows an injury site within the tendon, and as the tendon loses tension, it becomes wavier further down. We also see tearing to the muscle junction with a feather-like appearance at the arrows. This would be classified as a very high-grade hamstring injury, a grade 4C, and depending on the clinical picture, may warrant surgical repair. So we grade hamstring injuries with the help of MRI now. We no longer use the historic grading system of 1, 2, and 3. This has been replaced by the BAMC criteria, which is the British Athletic Muscle Injury Classification. This ranges from 0 to 4 and A through C. It's a busy slide, so let's just simplify it a little bit. So really, to simplify the BAMC classification, if it's a muscle-only injury, then it's a grade A. If it's an injury at the junction between the muscle and tendon, it's a grade B. And if it's a tear to part of the tendon or all of the tendon itself, it's a grade C. So is this really relevant? Well, yes, it helps us to stratify the risk of re-injury. We know that grade C injuries, where the tendon is involved, will take a lot longer to heal and also has an increased risk of re-injury. Also, knowing the tissues involved in the injury with the help of the BAMC grade plays an important part in planning rehabilitation. When a track and field athletics group followed the BAMC graded rehabilitation protocol, the re-injury rate was dramatically reduced to 2.9% over a 4-year period, which is pretty impressive when we look at the re-injury rates overall. As well as that, not only is it helpful to stratify risk of re-injury and help guide rehabilitation principles, the BAMC grade gives a good predictor of return to play times. When working with athletes, often the first question the athlete will ask you is, when can I return to play? The grading system allows for an estimated return to play prediction. It's not a crystal ball, however, and there are many other factors that will influence return to play time, but it's as good a tool as we have currently to help guide the prediction of return to play. Oftentimes, a rescan with MRI at the 6 to 8 week mark can be helpful to assess structural healing. And this often comes in helpful when dealing with a target of a short time frame of return to play. It can give the athlete an objective marker of structure of injury at that time point and forms part of the evidence for which the risk of reward risk decision making comes into play. So as a sports and exercise medicine consultant, our assessment of hamstring injuries always starts with a detailed history and clinical exam. Identifying the mechanism and the clinical cues, as well as prior history, is utmost important. Knowledge of the context of the injury, alongside when the target of return to play from the athlete's perspective, is also important. We review MRI images to help grade the injury according to the BAMC criteria, and for some hamstring injuries, we may carry out a point-of-care ultrasound assessment. That can be helpful at times for decision-making around some of the higher risk injuries. Generally, we like to have objective physical and functional parameters to help guide stages of rehab. A process we call the hamstring rehab lab, where with the help of our SSC and physiotherapy colleagues, we'll assess strength, plyometric and biomechanical measures to give the individual objective targets of rehab. At the Sports Surgery Clinic, we use multi-joint strengthening strategies to achieve the aims of rehab. Lumbopelvic control basically means the ability to control the pelvis effectively during movement, and it does represent an important aspect to successfully rehab and prevent hamstring injuries. An individual with an excessively anteriorly tilted pelvis or a pelvic drop is already at a biomechanical disadvantage with increased tension placed in the hamstring muscles. Poor trunk control can also lead to further compensatory mechanisms in the lower limb, which can increase the risk of hamstring injury and influence running efficiency. Assessment and optimizing running mechanics with each individual athlete is also important. Often the hamstring is the victim of inefficient mechanics at the trunk, pelvis, hip, and ankle. Identifying the reasons behind the recurring injury will lead to a more successful outcome. High-speed running, as we know, is the commonest mechanism for injury and then therefore forms a key part at the end stage of rehab. Delivering optimal rehab strategies represents the most effective method of a faster return to play. By addressing these biomechanical and movement pattern dysfunctions, it's also possible to enhance athletic performance and reduce the risk of future injury. The use of platelet-rich plasma has gained a lot of attention in tendon injuries. It is common practice across elite sport in other countries to have regular PRP injections after hamstring injuries. The evidence of effect is mixed, with some studies suggesting a shorter return to play time when PRP was used. It doesn't form part of our standard management process at SSC for such injuries, but we have it available to use under ultrasound guidance on a case-by-case basis. We're also lucky to work alongside some excellent orthopaedic surgeons some of whom have expertise in hamstring tendon repair. Surgical repair is limited for the very high-grade tendon injuries, and thankfully such injuries are uncommon, but it's great to have a team to be able to deal with them when they do occur. We've spoken about many of these prevention strategies in the management of hamstring injuries. Prevention of recurrence forms a vital part of management of the actual injury itself. Just to highlight a few from the list. So the FIFA 11 Plus warm-up protocol has helped reduce both hamstring and ACL injuries by about 60% in competitive soccer. The Nordic hamstring exercise protocol has helped reduce hamstring injuries by 51%. We know that clear lines of communication between medical and coaching teams have shown to reduce injury. So if you're working with a team, consider your systems of communication for injury risk. I suppose of utmost importance, prevention of the next injury starts with appropriate management of the initial injury. So just to run through a quick case discussion of an athlete I recently managed. This was an inter-county GA player. He was injured during a game. The injury occurred whilst running and rotating with a hand pass. Initially, the player thought it was a low-grade injury, but he just didn't feel quite right and was worried as he's previously been through recurrent hamstring injuries on that same side the previous season. His physio asked me for an opinion. So as we previously discussed, it can be very difficult to clinically tell from just examining someone without imaging if there's tendon or muscle involvement. In this player's case, he didn't feel a pop. However, he was tender more closer to the knee, over the region of the T-junction. There was a small amount of bruising noted also. His strength was good when I saw him at 2 weeks, but he felt his hamstring was vulnerable while trying to increase his speed, especially when trying to run on the turn. And this apprehension was reproduced with an Askling H test in the clinic room when I saw him. So this is his MRI, and we'll just run through the slides. So we can see on the right-hand side of the picture, a white high signal, which shows an injury at the tendon of the T-junction. Now, with these injuries, they have a very large and high increased rate of recurrence of injury, up to 60%, and can often present very subtly and not very obviously. So the player himself wasn't too surprised, but oftentimes we can be shocked by the high rate of injury with subtle clinical signs. So we helped guide the player alongside his physio through the phases of rehab. Given it was a tendon injury and a high-risk injury, we delayed higher speed running and high eccentric load of rehab to a little later in the rehab phases. We repeated an MRI at 4 weeks, which gave the player and us confidence that there was signs of good tendon healing. There still remained a little amount of edema or inflammation around the muscle tendon junction, so all was not clear yet, but in as good a situation as we could have hoped for. On ultrasound, there was no dynamic gapping, which also gave us further confidence. With the help of our hamstring rehab lab team here at Sports Surgery Clinic, we assisted the player and his physio with objective markers. He had regained concentric and eccentric strength of his hamstring muscles, both right and left, and his running mechanics had improved also with some coaching. He returned to a phased return to pitch-based training. Following a discussion then with the player's coaching team, who were aware that there were certain movements that were higher risk of re-injury, he managed to return in an adapted role for an important match at week 7. He then subsequently returned to full play and performance at week 8, and thankfully didn't have any further injuries in his hamstring for the rest of the season. So overall, we're very lucky at the Sports Surgery Clinic to have access to all facets of management and assessment of such injuries. If you have a hamstring injury that you feel needs attention from us, feel free to let us know. So thanks very much for listening this evening, and I look forward to any questions that you may have.
Ronan, thanks. Really interesting talk. We've got a lot of questions coming in. So I'm going to start with first question. What are your favourite prehab hamstring exercises?
Yeah, no, interesting question. And I suppose
there's not really a one size fits all approach for all hamstrings. It does depend on the individual, but generally there's a number of different programs that have been shown to reduce the risk of hamstring injuries. People might be familiar, so some physiotherapists in the room, if they're might be familiar with the Astling's L protocol, and really involves 3 exercises to increase the hamstring length. That would be one thing I would look at. Prehab can always be, you're preventing injury, but it almost rehabilitation or injury prevention and injury treatment is almost the one. So increasing strength through their hamstring as well. So the Nordic Hamstring Program is another program to improve hamstring strength over time, and that's been shown to significantly reduce hamstring injuries, as we've mentioned there already. So those 2 programs would be 2 I would direct people towards, really. But I think getting assessed properly to make sure that you're on the right program yourself, is probably the most important part, because there's no generic really program one for all.
Okay. Damien says, Ronan, we are currently participating in strength and conditioning program, and there is not an emphasis on sprinting at present. Could you discuss the importance of sprinting, acceleration, deacceleration on preventing hamstring injuries, and when to return to running after a hamstring injury?
Yeah, so 2 questions there, really. I suppose the first part of the question with the acceleration and deceleration. So really, mechanism of injury, you really want to try and recreate that in your rehab to make sure that the player or the athlete has enough robustness to have an increased threshold really above that mechanism to cause that injury again. So if the injury was more than likely an acceleration or deceleration, it's going to be a really important part and facet of their rehab. So in terms of prevention strategies and working with teams, obviously S&C and strength and conditioning is extremely important, as we all know. But absolutely working on high speed running, working on acceleration and deceleration. We know that over time, if you have increased your exposure, you've maintained your ability to sprint and to high speed run, you do reduce your risk of hamstring injury. So that's so important. So acceleration, deceleration, high speed running would fall under the one bracket really of maintaining that running. In terms of when is the ideal time to return to run after a hamstring injury, it really depends on the type of injury. So, as we've spoken about, the 3 main types being the muscle injury, the muscle tendon junction injury, or the tendon injury, is a completely different return to run process for each of those 3. So really getting the diagnosis correct will depend on your progression to run overall, really.
Okay, thank you. So there's 2 questions here about on supplements, if we just want to cover those. Someone's asking about collagen. Does it help maintaining healthy hamstrings? And can supplements of any sort help with cartilage, ligaments, etc.?
Yeah, so look, I suppose there has been quite a lot of research done in the last number of years on supplements, especially around tendon health. It's really, I suppose, the cherry on top stuff, I suppose. If you miss out on the strength, and you miss out on the high speed running, and you miss out on the ability to jump and sprint and have that rebound plyometric type strength, well, if you miss out on that, then there's no point in taking supplements, I would say. But if you've ticked all the other boxes and you're in a good position, collagen and vitamin C has been shown in some instances to improve your ability to improve tendon health by about 5 to 10% for some people that already tick those boxes. So there is some evidence, especially for, let's say, the competitive athlete. Many will be taking them anyway. I suppose the conscious thing with athletes as well is to make sure that they're taking batch tested supplements as well. So make sure that it's from a reputable source,
Yeah, lovely, thank you. Are there any typical biomechanic risk factors for hamstring injuries?
Yeah, no, good question. I suppose really looking from the ground up, so looking at the person's ankle range of movement. Oftentimes people might have had a couple of ankle sprains and they may have lost some of that ankle movement. Keeping an eye on how far they can bring their knee over their big toe or their ankle dorsiflexion movement. People that reduce dorsiflexion movement have an increased risk of hamstring injury. Then coming up to the knee with reduced knee extension, i.e. the hamstring gets quite tighter, that kind of shortened hamstring muscle has an increased risk of injury as well. So working on that hamstring length over time through stretching and through the protocols like the Astling L protocol. And then as well, coming up to the hip. So if you've got reduced hip movement or inflection or an extension, you have difficulty really bringing your swing leg or your follow leg through. and that can increase tension on the hamstring and increase the risk of injury. So I suppose in essence, really improving the range of movement of the joints and improving the length of the hamstring as well as the strength of the hamstring is kind of the three key biomechanics. But I suppose the question remains as well is what's perfect running form and what's perfect biomechanics, and there isn't really such a thing as perfect. So really having an assessment of your biomechanics after injury can be helpful to identify a number of risk factors, but we never tried to change some of these biomechanics drastically. It's really trying to work with them to see what can we reduce in terms of risk of injury. Is there any particular movement patterns that they're bringing their body into that might be increasing that risk? But yeah, there's no perfect form of running or no perfect biomechanics of running, but there are a couple of different risk factors for hamstring injuries with that,
Okay, thank you. Someone's here. How can you prevent chronic scarring from occurring?
Yeah, so good question. I suppose it's a very difficult question in many ways. I suppose if you prevent the recurrence of injury is the best way to prevent that chronic scar from forming. So managing the initial injury properly is the best way to prevent the chronic scar. Unfortunately, we see many people and athletes and players that will come to us after the second or third or fourth hamstring injury in the space of maybe even 12 months. And it's a really difficult injury to manage. It's not like a day one injury or an injury that just occurred. It's a tendon that generally has had to heal 3 or 4 times and has probably broken down 2 or 3 times. So really managing the first injury is the best way to reduce that chronic scar from forming.
Okay, thank you. Is there a link between REDS and higher rates of injuries such as the hamstrings?
Yeah, so I suppose for many people listening, REDS, great question. REDS is an energy deficiency in sport syndrome, basically, that it happens quite a lot when athletes under fuel or they don't take enough fuel or calories into their body to exercise, and a number of body systems then unfortunately lose out. So for females, generally they'll start to lose some menstrual cycles, so they'll start to have less periods, which is an obvious sign. For some people will get stress fractures. But yeah, there is definitely an increased risk of soft tissue injuries, including hamstring injuries for anyone that's under-fueled. Okay. So yeah, great question, and yeah, definitely a link.
Okay. Somebody here just said they've bilateral hamstring injury after being hit by a car and had meniscus tear to both knees. Left hamstring very painful. Will this settle, or would they need surgical intervention?
Yeah, got it. Unfortunate event there. I suppose getting an assessment first. It's hard to say straight off the bat what it needs. So it sounds like you need to be seen, assessed, and more than likely have a scan if you've had a significant injury like that. A couple of different surgical indications for hamstring injuries. Thankfully they're rare. But without a clinical assessment and a scan, it's hard to say. Yeah,
lovely, thank you. Ronan, this is, I think, from physio. They said they've a player with a grade B hamstring tear at the moment. They've immobilized him for 3 weeks to heal. When should he take him out of his POP and reintroduce ROM exercises?
They've immobilized him. It depends. So grade B hamstring injury. So generally wouldn't immobilize a grade B hamstring injury. I suppose movement is maintain that movement that they can maintain initially, and their strength. I wouldn't have immobilized somebody with a grade B hamstring injury. Generally, you wouldn't immobilize them. But again, bringing it back to the individual, you want to see what they can do functionally. Once the healing has taken part, i.e. the tendon healing, then you can start to load up the tendon more with some more plyometric load. But yeah, I think really going on function and making sure that the healing timeframes are correct as well. But I suppose tendon only heals with movement. So by immobilizing somebody and not moving somebody, the tendon is unlikely to heal. Okay.
What would you recommend for medial knee pain that's been caused by a tight hamstring?
Yeah, again, a difficult one because there can be a lot of different causes to medial knee pain. And is it really caused with a tight hamstring or not? I suppose you need to get a proper assessment to see what's causing the medial knee pain. Is it medial meniscus? Is it a medial collateral ligament injury? Multiple different causes for medial knee pain on that. So I would say I get assessment first.
Okay, lovely. Ronan, thank you very much for joining us tonight. So we are here again in the new year for another public talk on skiing. That's on the 17th of January. If anyone's missed this or you want to recommend these talks to anyone, they will be on our website in the next few days. And also we will be sending out a survey for people to fill in. So if you please fill it in and return it to us, it's always good to know if you've any particular topics that you'd like us to talk about, or all feedback we're grateful for as well, so they then help us produce the next public talks. Thank you.